I'm Luxmi, I'm tissue viability nurse consultant for Central and Northwest London, and my aim today is to share some of our really good experience that we've had using a new tool when we've tried everything else in our box. So thinking outside the box, because I know most clinicians I've met today, they go above and beyond. Everything, even off formulary, in formulary, we do everything to get our patient the best care, optimum care, and even takes them to healing. So my aim today is the impact that we're seeing, especially in the community. I come from community, stall wounds, the impact that it's having on our caseloads. How do we minimize that impact on their quality of life and improve their healing rate? And also, when do we start thinking outside the box? When do we start challenging standardized care? Said, we've had enough, we've tried it all, we need something else. So my findings from my caseload reviews, it had a profound impact on my patients' quality of life, resulting in more pain, isolation, reduced mobility, and my colleague this morning very clearly showed us how that social isolation can be debilitating. Lack of personal hygiene, which I've got a very important case to show you, because of lack of facility, personal hygiene has resulted in him having poor skincare for his legs, but this is how we made an impact in his life. Financial concerns. I've had young patients who had to pack work because obviously stall wounds, not able to heal, too much exudate, having to attend nurses 3 times, 4 times a week. And also we also very quick at saying, oh, this patient is very non-concordant. But very often it's not just so the non-concordance, it's why are they not adhering to the treatment that clinicians have suggested? Is there anything? Have we approached it in a different way? Sometimes they're just fed up because days in and days out they see the wound not healing, and as you know, this morning session we heard, people have said to them, you will leave with it. So this is a reason why I say, well, if I'm leaving with it, why do I bother? So the implication that we have seen, obviously from a community we know, we've got the NHS long-term plan that we want to nurse people closer to home and reduce hospital admission as much as we can. And also we know that antimicrobial stewardship across the UK, very important, how much and how prescribing the antibiotics. But for us as the healthcare system, it is creating further challenges because then we've got sequin coming up, we've got cost effectiveness on the NHS. Are we cost effective enough? Are we using too many dressings, too expensive dressings? And what other challenges that's impacting on our budget? My first one is this lovely gentleman there. He is the one who unfortunately lives in a shared accommodation, and because he doesn't get along with the people in where he lives, he was placed there. He doesn't use the facility to have a shower. So as a result, healed beautifully a few years ago, was on compression bandages, but because of his high BMI, he cannot wear hosiery. And this is one of the gentlemen who's been labelled as non-concordant, but getting down to wear that hosiery was really painful for him. Got him solution, got him some wraps. He loved it. He's still wearing it, he's managing it well, and we haven't seen any non-concordance since then. However, his legs happened to break down because they were really dry, and these happened to pick one of the dry skin. An ulcer form, obviously we know the root there, it became an ulcer, went to practice nurse, but didn't go to practice nurse straight away, had it been a bit of cling film over it, Dettol it, obviously he's tried the whole thing. Went to practice nurse and then referred to us after 7 months. That's my day 1 of assessment with him. Tissues were very unhealthy, heavily colonized. There was no systematic signs of infection when I look at him, but just you could see his hygiene needed some help. And obviously his practice nurse has tried everything before referring to us. That's him. Lovely gentleman, very caring and very eager to cooperate. We decided, okay, the practice nurse has tried everything, antimicrobial, silver, antibiotics, cleaning, skincare, but because he didn't have the facility to wash his legs at home, that was where the skin was building up. And this is where, as TVN, we thought everything is being done, what else? And that's where we start thinking outside of the box. He doesn't use the bathroom. Could we come up with a solution? And today's the opportunity. You got loads of companies down there. Just, I'm not telling you change your practice for everybody, but always get that extra tool in your box. And this is where we went for one of the wipes that we thought will benefit from the patient. It was easy for him to use, and it was that one thing that he's agreed, because yes, I can use it for the other part of my body as well, because he realized he hasn't had a shower for years. He's using it beautifully, but then as TVN, I have used my lovely magic tool, and my whole team is here today to support me, which I'm very grateful. They love it. They swear blind by it today. It's the little dermal curette that we use. It is a form of debridement, but when using the dermal curette, what we have done, if you look at that wound here, and the state of it, the peri-wound and the wound bed itself, what we did, we went to this one. This is the same gentleman who's been back and forth to practice nurse 3 times a week for 7 months. And this only from day one, after the first curette, that's my picture there, 4 weeks after, he's almost healed. And as we speak, he is healed, but the GP is now prescribing the wipes for his personal hygiene. But it's a difference that we've made by just thinking outside of the box, and this is the reason why I say, for some of you it might not be new, but for most of us it will be, what else? Always challenge yourself about the what else. And this is another one again, referred to us after practice nurse has tried everything. Had wounds, referred to us, this gentleman is non-concordant. We don't know why. Well, try compression. He's been in everything. Can't tolerate compression, pain, exudate. He's going to practice nurse every other day because the wound was too wet. He's been admitted for cellulitis, and it's only after he left intensive care unit that he was referred to us, not before that. Again, we've done our holistic assessment. We didn't just look at the hole in the patient, but we look at the patient as a whole. He was brilliant. He had his full compression bandages, taught him how to do his ankle exercises, his leg exercises, explained to him the importance of good diet. He loved his McDonald's. We thought, I'm not going to tell you not to stop eating McDonald's, but instead of 3 a day, maybe we could have 1 a day and have something else. And dietary intake was a bit of a challenge. I was worried that I would get a complaint against me, but it didn't come because obviously I stopped his McDonald's. And obviously the wound bed got stalled after some months of using compression, although he was under our care because we were sharing care with his practice nurse. And we got stuck here. For weeks, it just didn't move. And this is exactly when we thought, okay, compression is there, exercise is there, elevation is there, concordance is there, skin care is there, what else? How do we move that forward? And dermal curette was there. We curette him, we remove all the biofilm because that thick layer that you saw here was actually not slough, because it wouldn't budge with antimicrobial, with gel, with nothing, but mechanically we remove it. And the MMPs, with the exudate, was very high actually. And this is the reason why the dressing wasn't being managed properly. Just within 6 weeks. And as we speak, his poster is actually downstairs, he's healed. And he's one of the patients that we actually keep curetting every 2 weeks. So it's just, we didn't want the biofilm to come up, so every 2 weeks we give it a curette and just to manage it. And obviously we've got the healed picture downstairs on the poster. But again, it's just me, TVN, and my team. We know we've done everything. We've ticked all the boxes. Holistic approach was there. Best practice was there. But what else? Because even we get stuck sometimes. So this is the reason, this is a time when you have to take a step back and think, and for, are we doing everything? Is there anything else we can try? And this one is my best one. recently introduced to him. I didn't know him before. He used to be in army, and obviously due to an accident he became paraplegic, and he's been wheelchair bound. He's been self-managing, district nurse visiting him every day. So, and because he needs twice daily dressing change, Dian's visit in the morning, and himself or his daughter of 7-year-old does his dressings in the afternoon. And yes, it broke my heart, this one. He was very depressed, and his aim was not to heal that one. He's lived with it for 3 years. His GP has told him, you won't die with it, but you will live with it. So, he said, you won't die because of it, but you will live with it. So he had it in his head that he will live with it. And obviously, my aim was, what is it that we want to achieve? My aim on my paperwork wasn't heal the wound, because we didn't have the magic wand, but he wanted, what he's wanted was to be able to go to the park with his daughter. Things like that. Could we do it? I was worried. Pressure was on me. I didn't know I could, but I thought, you know what, let's try. There's no harm in trying. Eskin was there, worked with district nurses, had negative pressure, had all sorts of negative pressure, I can promise you that, and didn't work. Silver for 4 months, and he's had different silvers that I've seen. Some of them I've never used in my life. I went there and I saw in the cupboard, I thought, oh, what's this? He said, oh, that's a type of silver that I got from the internet. So he's tried everything, honestly, but not successful, and the dressing was not staying in situ. That's him. And because of where it is, it was very hard to dress. So you were having to do a bit of blue Peter. So if you use foam dressing, you can't use one. You have to use two. And if you're using foam dressing, you will have to cut a little triangle just to be able to fit that. And very, very challenging to dress. Obviously, we've started on some gel. We've done I use my magic wand, which is my curette. That's why I said it's my magic wand now. And you can see it's very chronic, very, very chronic. I had to do something because the exudate was terrible. And the smell was disturbing for him as well. He's lost a lot of weight. He said to me in the last 12 months only, he's gone 2 size trousers down. He's lost a lot of weight. And he only wears joggers now because of the exudate in his clothes. And he has to keep taking them to the laundry. So we curette it. We use an enzyme alginate gel because obviously we didn't want to use silver anymore. He's had too much. My aim was not, my focus was on the heal the wound, but my focus was the exudate management of the wound. And what else can I do to prevent that much laundry so that he can go out even for 2 hours in the park without worrying, have I got a wet trousers? This was my only aim. And obviously we went from twice daily dressing to 3 times weekly after just about a week of implementing the curette and the enzyme alginate gel. He was worried. He said, are you sure? So just to give him peace of mind, I said, look, the district nurses are here. We're not pulling them out. If you feel it needs changing the next day, call them. And the DNs, just for reassurance, always give him a call. Say, do you think we should come today? He will take his mirror, check his wound on the sacrum and say, no, I'm good. And it was empowering at the same time. And that is just 2 weeks. So I'm not sure if you will remember the wound, but I will just bring that one back. Can you see the cavity in these 2 wounds? And this is the wound bed after 2 weeks only. We had no exudate on that one. This one has reduced in size, and I can see the wound base in it, which I could not when I first saw him. We did use different dressings because obviously my challenge was the exudate. The MMPs was very high, so we had to focus on exactly what else, but we have been curetting it frequently to make sure that wound doesn't go back on the stalled area. And after 8 weeks, the top one is half the size. He's still on the MMP dressing because that's helping the exudate at the same time, but he's not being curetted, and he's only using one foam now, which is a 10 by 10 from 2 different 15 by 15, which we had to even cut triangles and holes in there. So that's really what I wanted to share with you today. It's our passion, it's what we do best, it's what we like doing. Let's just not stop, because formulary tells us this is what you have, this is what you got. Sometimes as clinicians, take that step back and think, what else? Hopefully today you will go home with a tool in your box, an additional tool to use. But wound care, and these are my trust values, and I swear blind by them. For me, my aim on none of these patients was to heal them. It was just to make sure I improve the quality of life. And this is what we do best. So we've empowered them, we've told them, what do you want me to do? And we've done that. I've empowered the clinicians using Curette, because we all talk about biofilm now, but obviously how can we make it work for us on a daily community trip safely? And also working with the patient, like partnership, because these patients know what they want. We implemented care contract in my trust because we do not want to hear the word non-concordance. We don't use it anymore. We do a care contract with the patient. If we feel there is, as district nurse say, oh, can you please review Mrs. Smith? She's very non-concordant. We do a care contract with them, with partnership. We agree a care. The same copy goes to them. If they step back from the agreement, we thought, but we did have that discussion, what happened? And that, because they know that copy goes to their GP, they was like, I'm not stepping. It's like us signing a contract for a mobile phone. We're not going to not go with it. And exactly what we're doing with our patient, working in partnership with them. So obviously compassion, respect, empower them, and always keep them at the center of your care plan. So that's from me, thank you. Any questions? I'm here.